I want to talk today about RCA engagement, specifically the 11 pitfalls. This talk complements my prior RCA engagement talks. A quick reminder here, the RCA is on top of the coronary sinus of Valsalva around the sinotubular junction, about 1.5 to 2 centimeters above the valve. When engaging the RCA, we start at the valve, the right cusp. We touch that right cusp with the catheter, then we pull with a clock about 90 to 180 degrees with both hands. The same technique is used for both radial and femoral. However, from femoral, the catheter tends to dive a lot more than from radial, which means that you need to pull the catheter significantly more when you're engaging from a femoral access. So you clock and pull more from femoral than from radial access. In fact, from femoral access, you may position your catheter a little higher above the sinotubular junction and clock with a pulling tension to engage the right, and the catheter will dive in. Now, here are the 11 caveats in general RCA engagement. Those caveats apply to both femoral and transradial engagement. The first two, the catheter tips comes too low after the torque, or the catheter tip comes too high after the torque. And how do you know you are too high or too low relative to the right coronary artery? Again, remember the RCA is on top of the coronary sinus of Valsalva, 1.5 to 2 centimeter above the valve. So if on non-selective puff, you see the nest of that cusp sinus of Valsalva, you are too low. If on non-selective puff, you see that convexity, that tubular aorta, you are too high. So if your catheter comes too low and on the non-selective puff, you see that nest, what do? Don't just pull up straight. It's not going to jump in. What you do, you counterclock a little bit, make the catheter look at you a little bit, then you pull with a slight clock and it will go in. And after it goes in, you can push it a little more. If your catheter comes too high, don't just push it down. It's not going to go. What you do, you reverse torque, you counterclock, then you push back down to the valve, then you start over with less pull so you don't come up too high. Two general tips for whenever you are lost during your RCA engagement. Always go back down and touch the valve and start at this base of operation. So you know whether am I too high, too low, just start back over at the level of the valve. Number two, do non-selective cusp angiography in LAO view to see if you are too low or too high. If on that cusp angiography you don't see the RCA origin, well, consider doing the cusp angiography in RAO view because your RCA takeoff could be anterior looking at you, so you may not see it on cusp angiography in an LAO view. Or you could be in the non-coronary cusp rather than the right coronary cusp. You think you are in the right cusp, while in fact you are in the low but more posterior non-coronary cusp, and RAO will show you that, as I will explain later. So those are two important tips. Go back down to the valve, touch it, and start over, and do non-selective cusp angiography in LAO and if needed in RAO view. The fellow here was trying to engage the RCA with no success. On the non-selective puff, you can see why. He's in the left coronary cusp. And you can tell that because the ridge is on this side, whereas you see the nest on that side and the left coronary. So you need to get back down to the right coronary cusp. And don't try to engage the RCA from the left cusp because you're going to come way too high. So you need to get back down to the right coronary cusp, then engage from the right cusp. And how do you get back to the right coronary cusp? If the catheter is in a neutral position, The way you get back down to the right cusp is you counterclock it to make it look like this, then you push it down, and when you get down, then you pull with a clock to try to engage the RCA. Now, if while torquing from the right cusp, you keep jumping onto the left cusp or you keep falling into the ventricle, what do you do in this case? This is the jump from right to left cusp as you're trying to engage the right coronary. And look here, we're in the right cusp, we're trying to engage, and we jump into the left cusp. So what do you do if this keeps happening, jumping into the left cusp or into the ventricle? Again, do not try to engage from the left cusp. First, you counterclock from the left cusp and push back down the catheter toward the right cusp and touch the valve. Make sure that you are low on the valve. As you can see here, we counterclock and we push back down to the valve. Then you have to try to clock and pull while remaining very low to prevent that catheter from jumping back up. Once you're in the right cusp, if you clock and just pull as normal, you might jump right back onto the left cusp in such patient. So you have to clock and barely pull. Clock while staying low, barely above the valve. Do not pull much, keep it low. To transmit the torque while staying low without much pulling, you must push and pull the catheter at the sheath level with your left hand. So you clock with both hands, and that hand does a slight push and pull while you're torquing until the torque transmits and the catheter starts looking at you. Once the torque transmits and the catheter starts looking at you, then you can clock and pull more. At this point, the catheter has a momentum toward the right side of the aorta, and it's not going to jump to the left cusp. So initially, you clock with slight pull and push, constant pull and push with the left hand, and once the torque gets transmitted and the catheter is looking at you, then you can pull more comfortably and clock more, and the catheter will engage. And this is what was done here. Initially, we transmitted the torque to make the catheter look at us. Then we can pull and clock more to engage the right coronary. After we had the momentum toward the right side, we were able to pull and clock more. Moving on to another pitfall. If you cannot engage the RCA in the standard fashion in your LAO view with a standard JR4 or AR1 catheter, what is your immediate next thought? Well, one, do a non-selective cusp angiography in LAO. And if you still don't see the coronary, you have to think the RCA has an anterior takeoff. Now, you may see it, that RCA in LAO cusp angiography, but if you don't see it at all, also think anterior RCA takeoff and do a cusp angiography in an RAO view. Here we were able to see it in an LAO cusp angiography, and you can see that RCA is not arising from the right surface of the aorta. It's arising in front of you at the center of the right cusp, the so-called anterior takeoff. You should always think of that whenever you encounter difficulty engaging the RCA, especially when you don't see it in cusp angiography in LAO view, or if you see it in this fashion, in the center of the cusp. So this is that anterior RCA takeoff. It's fairly common. And whenever you have an anterior takeoff, there are two tips you need to use to engage the RCA. One, you may need an RAO view to display that ostium in front of you and to allow you to aim toward it. Or if you use LAO view, make the catheter look at you while you're engaging. And number two, you need to use a catheter that can reach that anterior takeoff. The problem with the Judkins right catheter is that it only elongates and reaches the surface of the aorta when it's aiming toward the right side of the aorta. It doesn't elongate when it points toward the anterior surface of the aorta. So you need a catheter with a longer tip, such as Amplat's left 1 or maybe AR2 catheter in patient with a small narrow aorta. AR2 may reach, but typically you need an AL1 catheter. And this is what was done here, AL1 catheter in an RAO view, and you can see how we engaged aiming toward the anterior surface of the aorta. And this is another case, same thing, AL1 RAO view. And by the way, this same idea also applies to left coronary engagement. The idea of anterior or even posterior left coronary takeoff warranting RAO view for engagement. This is a standard left coronary takeoff that we engage in an LAO view here. LAO view for standard takeoff. But when you cannot engage the left coronary in LAO view and non-selective puffs keep showing you the ostium is around your catheter, but you are out of plane, not able to selectively engage, this means the takeoff is actually either anterior or posterior. And in an LAO view, it would be either looking at you or away from you. It will be here in an LAO view somewhere. So in those cases, go RAO and sweep that left cusp antero-posteriorly. So RAO and sweep that left cusp antero-posteriorly. The takeoff may be anterior on that surface of the aorta in an RAO view, or it could be posterior, close to the left cusp ridge, or maybe in extreme anterior or posterior takeoff looking at you, even in an RAO view. It will be somewhere here or there. So use RAO view whenever you encounter difficulty in left coronary engagement as well. I will move on to the next pitfall. Keep into account the shape of the aorta as you are engaging the right coronary artery. Compare, for example, this aortic configuration, a vertical aorta in a young patient, versus an elongated, dilated, horizontal aorta in an elderly patient. In both cases, the RCA originate 1.5 to 2 centimeters above the valve. However, the vertical level of that RCA differs between the two configurations. In this patient, the right coronary artery will arise at the same horizontal plane as the valve. It's still the same distance from the valve, but it's the same horizontal plane. So to engage that right coronary artery, you have to aim to the horizontal portion of the aorta. If you try to engage that right coronary artery on the vertical portion of the aorta, you're already way too high. So you have to aim on that horizontal portion of the aorta, unlike this patient where you aim in a more vertical portion to engage the right coronary artery. The right coronary here seems to be displaced downward and is pointing more downward than usual. And the way you can tell the aortic configuration, you don't need aortic angiogram. You just look at your catheter shape after it touches the valve. You can see that the catheter will have a long horizontal portion in this patient with elongated aorta. And keep in mind that whenever your non-selective puff shows you that convexity of the tubular aorta, you are already too high. You are already too high here at this level, even if you're on the horizontal portion of the aorta. This is an example here, and you can see where the right coronary artery arises in this patient with horizontal aorta. And you have to aim here low to engage it properly. This is another case. Just the catheter tells you that the RCA origin should be around here. Don't aim for the RCA here. If you aim for the RCA there, you're already way too high. This is where the valve is. you have to aim somewhere around this area on that horizontal portion of the aorta, around the same level as the valve. I will move on to the next pitfall, a very common pitfall. Let's say we're trying to engage the right coronary artery. Our catheter is looking like this, and this is the pressure waveform. Your immediate reflex is, I am in the conus branch. And I'm damped because I'm in a small artery and my catheter is occluding that conus branch, hence the damping. So the conus is an RCA branch that supplies the RVOT. It has a separate origin in about 35% of the cases, and it would be arising more anteriorly than the RCA, and it will be pointing more upward than the RCA. So in those cases, as you're trying to engage the RCA, you will encounter the conus branch before you encounter the RCA. What do you do in those cases when the catheter gets into the conus branch rather than the true RCA? And the way you recognize that is that the catheter is pointing upward and your hemodynamic shows damping. There are three ways of dealing with this. One, if your catheter is not too deep in the conus, if it is barely in, what you can do, you can keep clocking your catheter while pulling to make the catheter go more posteriorly. In those patients, the conus is here, the RCA is here. So if you keep clocking from the conus level, you will reach the RCA, especially while pulling, because the RCA points more downward. So that's one. However, more commonly, the catheter tip is already too deep in the conus. So you cannot just keep clocking while pulling because you'll be clocking the actual conus itself. So in those cases, what you need to do, you need to get out. You counter clock and pull, get out, then go back down to the valve, touch it, then clock and pull, and this time exert more clock and more pull tension on the catheter so that you don't fall in the conus. That more clock will make the catheter point more posteriorly, more readily, and the more pull will elongate the catheter and will make it shaped more down, so it will not hook that conus. If that technique doesn't work, then you need to get a catheter that points down. And more commonly, if you're using a JR4, you can use an AR1 or an RCB. And commonly I use an RCB, which would point me down. RCB is the right bypass catheter, which points down. I will move on to another caveat, the seventh caveat. The JR4 keeps flying out after engagement, especially with breathing. What do you do in this case? If the RCA has a standard takeoff from the right side of the aorta and the catheter is coaxial with that origin, you can just push it in after engagement to stabilize it. Now, if the catheter is barely in, and that's why you're flying out, so what you do in this case, you just slight pull and clock to make the catheter more coaxial and deeper. So you slightly pull and clock, and the catheter will go in deeper and will be more coaxial. Now, if you have an anterior RCA takeoff, and that's why your catheter keeps flying out, well, you need to get a catheter that reaches that anterior RCA, as I explained. In this case, don't use a GR4, get an AL1, and be more selectively engaged. And this is a case where the catheter flies out because it's barely engaged and not coaxial. So clock with a slight pull to be more deeply engaged here. Eighth caveat, common with early fellows, you engage the RCA, but your catheter flew out because it's over-torqued. So that GR4 is over-torqued, and it will keep rotating 360 degrees after engagement. So how do you correct this? You engage using less torque and more pull. You try to transmit your torque by pulling a little more and torquing less. Or in cases of difficult torque transmission, what you do, you clock while your left hand at the sheath level is doing those pull and push motion to transmit your torque without you having to over torque it. Or what you can do as your torque is being transmitted and the catheter is starting to hit the right side of the aorta and the RCA, counterclock a little bit to slow the momentum and prevent the over torque. I will move on to the ninth caveat, which is actually a common caveat. I want you to know that very well. It's a common caveat that we don't think of very commonly. So here we try to engage the RCA. We started at the lower cusp, what we perceived as right cusp, and we went up and down the cusp, and we did non-selective puffs, but we could not see the RCA. What is your next thought? The next thought is always think the RCA has an anterior takeoff. That's why I couldn't engage it, and that's why I couldn't see it on that cusp in geography, in an LAO view. But what's your other thought? Always think I could be actually in the non-coronary cusp. I always assume that whenever we are in an LAO view in the lowermost cusp, we are on the right cusp. And typically, especially from a radial axis, the catheter wants to go to that right cusp, which is more anterior compared to the non-coronary cusp. However, keep that caveat in mind. You may actually be in the non-coronary cusp, and that's why going up and down, you're not able to engage, and the non-selective angiography does not show you the RCA. And similarly to the anterior takeoff, the way you figure this out is by going in RAO and doing cusp angiography in an RAO view. And that will elucidate this caveat. So here is what we do. So in this patient, what we did, we went RAO to see, are we in the non-coronary cusp? Or if we are in the right cusp, is our RCA anterior takeoff? RAO will spread apart non-coronary cusp, which is the posterior cusp, versus right and left cusp. It will superimpose right and left cusp, but it will separate the non-coronary cusp. So that's what we did. And here on the non-selective angiography in RAO, you can see the aortic wall on this side, which tells you I am very posterior. I am the non-coronary cusp. And actually, you would see a ridge on this side, which tells me that the ridge on this side, therefore, I'm in the non-coronary cusp. Furthermore, you try to pull, and you would see a jump when you pull. Look here, we pulled, and you see a jump. That jump by itself tells you that you are in the non-coronary cusp, and you jumped. Now, you could have jumped in the right or the left cusp. And you can see here we jumped in the right cusp, and you can actually see the RCA. But typically, after you jump from the non-coronary cusp, you go back to the LAO view, you confirm you're in the right cusp, and then now it's easy to engage that right coronary in an LAO view. Also, doing that non-selective angiography in an RAO view will help us tell if we're actually in the right cusp and if the RCA takeoff is anterior. So it will sort out for us both the right cusp anterior RCA takeoff, and it will sort out whether we are the non-coronary cusp. This is another such case. Again, that non-coronary cusp pitfall is fairly common. So here we're trying to engage the RCA. We think we're in the right cusp, but we don't see anything on our non-selective puff. So the next thought is that we may be in the non-coronary cusp. What we thought is right is actually non-coronary cusp. So we went RAO to spread apart non-coronary from right cusp. And indeed, what you can see here on non-selective puff, you see the aorta is posterior, and you see a ridge on this side, which confirms to me I am in the non-coronary cusp. See the ridge here and the posterior aorta. So what we did here, we pulled from that cusp to jump. You can see the jump here. And after the jump, we move to an LEO view to see whether we are in the right or left cusp. And here on the non-selective angiography, you see that we are in the lower cusp, and you can see the ridge on this side here. Watch again the ridge on this side. So we are on the lower cusp, which is the right cusp in this LEO view. Then after that, it was very easy to engage the RCA with a pull and clock. Again, keep in mind, LEO separates right versus left cusp, whereas RAO will separate posterior, which is non-coronary cusp, versus anterior, which would be right or left cusp. I will move on to the 10th caveat. This is a case of severe, sharp, and calcified innominate aorta angle with inability to transmit any of the clockwise torque for RCA engagement. There are two major tips. One, it's very difficult to transmit the torque. Don't just keep torquing in place. If you keep clocking, you will kink the catheter and you will not transmit anything. So what you do, you have to clock with both hands while doing a lot of pull and push with that left hand at the sheath level so you can transmit your torque. So you're clocking with a lot of pull and push back and forth, few millimeters in and out with that left hand to transmit the torque. Keep doing so with the left hand until the torque transmits and the catheter starts moving and starts to have a torque momentum. Don't keep torquing. It's a slight torque with a lot of pull and push. Very slight torque with a lot of pull and push. That's the first tip. The second tip in this case is you have to torque with a wire in place. You keep a wire in to improve stiffness and torqueability and to straighten that innominate aorta angle and allow torque transmission and prevent catheter kink, very importantly. The biggest hazard in those manipulation is the catheter kinking if you over torque. So that wire will prevent catheter kink. And see here what was done. So with the wire in place and with the hand maneuvers I explained, with a constant pull and push with the left hand, we were able to engage the coronary. The problem though is that after we engaged, we took out the wire, and this is what happened. The catheter flew out. So another important tip in those cases is that it's not just enough to engage, it's important to stay engaged. And to stay engaged, you have to keep your hand locked into that torque position, and you have to keep the wire in. You cannot take it out. If you take it out, that aorta-innominate junction will coil and loop back on itself, and the catheter will fly up. So you have to engage and image while the wire in place. And how do you do that? You have to use an 0.18-inch wire so that you have enough room to inject with your diagnostic catheter while the wire in place. And you have to connect a TUI device at the back of your catheter so you can inject contrast while the wire is in place. And I would typically use an 0.18-inch V18 wire. Occasionally, you can even use an 0.14-inch wire and advance it a little bit in the coronary to further stabilize your catheter. This can be done using a diagnostic catheter. You don't need a guide. However, you can use a guide. And the advantage of a guide is that you can image even if an 0.35-inch wire is in place, because the inner lumen of the guiding catheter is larger and there is more room to fill it with contrast. Another tip in those cases is it's very important to keep an eye on the pressure waveform while you're engaging. When you kink your catheter, the pressure will be completely disfigured. So the moment you see the pressure waveform starting to deteriorate, it means you're starting to kink your catheter. You have to stop torquing early on and exchange your catheter. Don't wait until your pressure waveform is completely flat and disfigured, at which point your catheter is completely kinked and maybe even knotted. in which case it's hard to even take out. So keep your eye on a pressure waveform. Whenever you see any alteration, that means you're having an early kink, just exchange your catheter before getting a massive kink. I will move on to the final pitfall. If you fail to engage the RCA and you cannot see it on non-selective right cusp in both LAO and RAO view, and even after aiming for anterior RCA takeoff, the final thought is that RCA is actually arising from the left cusp. So what you do in those cases, do a non-selective left cusp angiography and see whether your RCA is arising there. And do that non-selective left cusp angiography in both LAO view and RAO view. Because the RCA could be arising close to the left coronary artery, in which case you will see it well in an LAO view, but it may also be arising from the left cusp toward this side anteriorly, in which case you're not going to see it in an LAO view. You will see it in an RAO view. That's the toughest RCA. That's arising from the left cusp anteriorly. You need to do non-selective left cusp angiography in both LAO view and RAO view and try to see where it's coming off. Frequently, you can get a hint that the RCA is arising from the left cusp when you're doing your left coronary angiography. You'll see that spill into the aortic cusp filling in RCA. However, when it's a little further away from that left coronary, especially that configuration C, anterior left cusp, you're not going to see a spillover into the RCA, and you have to do cusp angiography in two views to be able to visualize it. Again, keep that idea in mind. Whenever you're lost, do cusp angiography in LAO and RAO view. This is such a case where you could not engage the RCA in a standard fashion, so we did left cusp angiography in an LAO and RAO view, and we were able to visualize it. Then we engage it. This is in an LAO view. This is an RCA arising from the left cusp, and it's far from the left coronary. You do not see the left coronary on spillover. It's arising from the anterior left cusp. And the best way to visualize this is in an RAO view. Non-selective cusp angiography in an RAO view allowed us to see the origin of that RCA and allowed us to engage it using an AL1 catheter. For this configuration, you typically need AL1 catheter. For those configuration where you are from the left cusp close to the left coronary, the left side of the left cusp, not anterior, the left side of the left cusp, you may engage it using a Judkins left, typically a shorter Judkins left than the one you use to engage the left coronary. For both A and B, typically a shorter Judkins left.